Hello everyone and welcome to OncoDaily. I'm Amalya Sargsyan, a medical oncologist and VP for Research and Intelligence at OncoDaily. And joining us today we have Dr. Eileen O'Reilly, a medical oncologist from Memorial Sloan Kettering Cancer Center, one of the world's leading voices in pancreatic cancer research and the lead author of the RASolute-302 trial, which was one of the most talked about readouts at this year's ASCO. Dr. Eileen, thanks so much for accepting our invite and being with us today.
Thank you so much. Delighted to be here and look forward to our discussion.
So before we go into the data and the trial itself, let's look it a bit broader and back. Why, when speaking about pancreatic cancer, it's so important, and why the second-line pancreatic cancer has broken so many hearts for so long?
Yes, you hit on key points, right? This disease is particularly challenging at any time point, but even most so in the setting of when the disease is progressing and getting more complicated in the metastatic setting. It impacts health in significant ways for people in terms of appetite, energy, sometimes weight loss, sometimes pain, decreased level of functioning, and just overall poorer health. And we know that progressive metastatic pancreas cancer is prognostically worrisome. There are treatments in the current standard paradigms that have impacted outcome, but they leave a lot to be desired.
Thanks for sharing. Yes, and it makes, I think, the discoveries even more important in these kind of settings. So
Yes.
coming back, can you share with us a bit more on the trial and what was it about?
Yes, indeed, for sure. And perhaps even one step back from that to talk a little bit more about the biology and genetics of pancreas cancer. So this disease is characterized by presence of RAS mutations in a vast majority of individuals with this cancer. And most of these mutations occur in the G12 position, so G12D, G12V in the KRAS gene, and G12R are the three most common versions of KRAS. And then we see occasionally alterations at other positions, including G13 and more rarely Q61. And this may be important as we learn more about targeted therapy, but that's sort of the genomic makeup of pancreas cancer, along with other critical driver oncogenes. But RAS mutations are involved in growth, in metastasis, and development. And this has been known historically for many decades. But the changes come with the fact that RAS is now targetable in the clinic. And that leads us, fast forward to 2026, sort of summarizing many amazing labs and scientists' work. And that with the advent of understanding how to tackle the vulnerabilities of RAS with, novel types of drugs, that can be successfully done. So Daraxonrasib is a tri-complex inhibitor, so it targets RAS mutant state, RAS wild type state. It targets all of the versions of RAS to a greater degree, and it binds a protein in the cell called cyclophilin. It locks that into a tri-complex with RAS, and that switches off the downstream signaling. And that's how we think this drug works. So the RASolute-302 was a large phase III trial, 500 patients enrolled, half received standard of care chemotherapy and half received Daraxonrasib, 1-to-1, no blinding, open label study. And the highlights here, the top level outcome was a doubling and slightly more of median overall survival in the Daraxonrasib treated group relative to the chemotherapy group, supported by response rate that was almost tripled, not quite, but almost, doubling of progression-free survival and less pain and maintenance of global health, quality of life parameters for longer. So it hit all of the important benchmarks and was a clearly positive study.
Well, and that's why I guess the study was with standing ovation, and it really indeed changed a lot. And someone who was there from the first days of this trial, you were there pioneering and enrolling patients and seeing the responses even before the results got to all of us. So what was your emotions and when you saw the curves? Were you waiting something like that? from the daily life?
Yes, yeah, thanks for this. And it certainly has been our sense in the clinic when we started looking at these drugs, 4 years ago, and more for the first generation of the G12C inhibitors. But in particular, when we got to the pan-RAS and the allele-specific inhibitors, that there's something real happening, that these drugs are meaningful therapeutics and they are inducing responses and people are feeling it and feeling it relatively quickly. I think it was extraordinarily gratifying to see that translated true, and that signal that was observed in the initial experience really held up very reproducibly well in the phase III. And, its significance is not just that it's a new drug, but it's a new way of thinking about this disease. It's a new way of treating this disease, and that RAS is no longer, the non-targetable gene that it's been, and that it's hopefully setting the stage just for the start of a major change and a paradigm shift in terms of how we think about pancreas cancer and how we approach it therapeutically in the clinic.
Mm. And you have very nicely explained how the drug actually works and why the biology matters. And that's why the drug actually worked, because it was driven by biology. Before this one, there were another G12 drugs which were trying to be into clinic. What do you think? What was the success of this one? It worked, and the others were not as impressive results as this one.
Yeah, so there's been lots of ways of targeting RAS in the past, going back to farnesyl transferase inhibitors, but they mechanistically had many limitations. I think where the kind of evolution was in understanding the genomics for sure, that's again been recognized, but bioengineering and drug development and a lot of innovation in terms of the science and putting those all together with these critical observations from a lab in UCSF and a lab in the Harvard group was leading to this change. But the initial experience started with KRAS G12C, and that's about 1% of people with pancreas cancer, more common in non-small cell lung cancer and in colon cancer. In pancreas cancer, the single G12C inhibitors, the first generation, and indeed the second generation, they also showed a signal that these drugs can shrink cancer, progression-free survivals, and encouraging survival signals. But these were single-arm, non-randomized, but looked to be historically, looked to be more favorable historically relative to what chemotherapy might do in this setting. So, yeah, there was a hint a number of years back, but really the change is now in terms of what it means, because the current class of drugs targets essentially everybody with this disease.
So you're starting to use this into the clinic after these results, and are you going to use it more and more frequently?
Yes, I mean, we're looking forward to the FDA's review and decision, and hopefully that's in coming months. We and others are utilizing the early access program to provide Daraxonrasib to individuals that can benefit and have a similar setting to people who are included in the phase III as a bridge to being able to prescribe it in day-to-day practice. That's great. But now we want to also to move these drugs to every other setting in pancreas cancer. And that's happening in first-line trials with newly diagnosed untreated metastatic disease. There are activated studies in the post-op setting that will define the role of RAS targeting. Other therapies beyond Daraxonrasib, right? They're allele-specific inhibitors, and they have some potential virtues in that they are more narrowly focused against a single allele, and they can have high potency and may mitigate some of the toxicity that we see with the pan-RAS inhibitors. And combining allele-specific and pan-RAS inhibitors may be mechanistically, promising strategy in terms of delaying resistance, maybe giving them sequentially. Part of our challenge in the next number of years is sort of figuring out what are the key combinations that we need to utilize and develop in the clinic.
You've touched a few points that I definitely would like to highlight. The first was toxicity. So how is today in the clinic, the toxicity overall, do people discontinue it more? And especially the comparison arm was the chemotherapy, right? So which was pretty toxic, especially for these people who already have a lot of symptoms. So how it is manageable, or what will you share from the clinic itself?
Yeah, so going back to the RASolute-302 study, there was 11% of patients who elected to discontinue chemotherapy. There was 1% of people who ended up stopping Daraxonrasib, so quite disconnect there. And that's, I think was supported by the quality of life data that, and people felt better because the cancer was controlled better for longer. And we don't yet have details on what happened after people's disease had grown, but I suspect that there will be many more people who are strong enough and well enough in the post-Daraxonrasib setting to receive chemotherapy relative to the chemotherapy treated group of patients. So we have a lot to learn there, but going back to your question, the three big things that we see in the clinic are the one that's gotten the most visibility, which is related to the rash. I'll also speak just momentarily about GI toxicity and mucositis. So rash tends to come on a couple of weeks after starting. Most people will get some level of rash. For most people, it's manageable. We use and recommend prophylaxis. So before starting antibiotics, topical steroids, moisturization, sunblock, practical things. And there are a variety of interventions that are being looked at for those who actually do develop the rash. Now, when the rash is more active, that can require holding the drug, and it can often require, or at least if the rash abates, and sometimes 5 to 7 days, we see significant abatement, we reintroduce at the same dose. If it happens again, we might consider a dose reduction. For most people, that's that's been manageable, and because people are feeling better, they're very motivated to want to continue. That's been interesting. Just and we have to listen to the people we look after, right? They're telling us, and so the other consideration is early when we started, there can be some nausea and can be some fairly acute diarrhea in the first couple of days. Also able to hydrate, quick with Imodium, and to keep us posted. And later on, longer timeline, sometimes some stomatitis, and that can require care and attention, and occasionally dose holds, and more rarely dose adjustments.
It's especially important that you're saying that people are very motivated to continue. So
Hmm.
perhaps they'll also do most to overcome these toxicities. And
Yes.
as you tell,
Yes.
these are manageable, it seems, and we are learning. I think more people will need the experience of how to treat them, because you were, I think, from the first days and the last days, it was different how you were managing the drug.
Yeah,
But
I think that's exactly right. And just to build on that, right? Again, we're just at the start of all of this. I think as this gets integrated into practice, we will adapt and evolve and to manage these toxicities. And I think one doesn't want to minimize those in any way. But the hope is because people are experiencing the benefit and feeling the benefit, that's kind of an acceptable balance in terms of the quality of life impacts.
oh, yes. And you have also touched another topic which I wanted
Mhm.
to highlight. This was the combination and other future looking strategies. So, what's your thought, your idea? I know it's very early and perhaps some data is still very confidential to share, but just your ideas. Do you think that in the front line it will be combined with the chemotherapy? Some chemotherapy will be omitted. How do you think it will be evolving? What to wait for?
Yeah, thanks for this question. It's, where are we headed with all of this? At AACR this year, there were two cohorts of individuals with metastatic pancreas cancer untreated, who received Daraxonrasib as a single agent and received Daraxonrasib combined with gemcitabine and nab-paclitaxel. And both of those cohorts showed, again, similar signal of high response rate relative to what we might expect historically with chemotherapy. and 6-month periods of cancer control that were encouraging, and decline in ctDNA and clearance of ctDNA in a percentage. So suggesting that, again, significant activity in untreated disease. And that's the subject of the RASolute-303 trial, which is comparing those two interventions, Daraxonrasib alone, Daraxonrasib with gemcitabine and nab-paclitaxel, and sequenced onto Daraxonrasib, and control arm of chemotherapy. Chemotherapy, may delay resistance, may enhance responses. We'll look forward to seeing that combination. That's an important one. I think the other excitement is the fact that there may be non-chemotherapy combinations in frontline untreated metastatic pancreas cancer, right? And if we see a paradigm shift in later stage disease, to see that to a lot of people earlier on is very compelling. And we've heard the early readouts on top-line results looking at PRMT5 inhibitors with both pan-RAS and allele-specific inhibitors. And we'll be hearing more details on this very shortly, but that data set looks very encouraging, keeping in mind that PRMT5 inhibitors aren't for every individual with this disease, but they are for the group of people who have an MTAP deletion, which, depending on how you define it and look for it and test for it, maybe 25, 30%, maybe even a little bit more in pancreas cancer. So that's a real subset, and we look forward to seeing that combination. To me, the other big area is, can we combine immunotherapy with RAS target and convert some of these responses into a more durable setting? So that's one to stay tuned and look out for.
Yes, well, I think a few years ago, everyone would be very happy to hear these results. So
Yeah.
now we are looking into the future to see even more and better. And actually, I wanted also to ask about the durability. Um,
Mhm.
you touched this, but how do you see with this? I know that it's still early, that we'll need time to see.
Yes.
But what could you share with
Yes.
us?
Well, from the RASolute-302 trial and from the preceding phase I, phase II, both of those were published back-to-back months in May in the New England Journal, and show that in second-line setting that the degree of cancer control is about 6 to 7 months, right? So that's what we're hoping to increase in the frontline setting. We don't, again, have data yet for the pan-RAS inhibitors, or indeed for any of the allele-specific inhibitors, as to what the durability looks like in the front line. I think we're all encouraged by what we see in the clinic, but we'll need to see the readouts of these studies and understand, how best, as you were alluding to, how to combine these drugs, but maybe also how best to sequence them.
Mhm.
I'll make one other point that I think is important for the audience, that's the idea of a targeted therapy as a single agent in the front line, right? It's going to open up a new group of people that may not have chosen to take chemotherapy for their disease, or perhaps were not well enough for that. And again, that's not to say this drug is for people with poor performance status, but I do think it's going to expand a group of people that we're going to be able to treat. And right there, that's going to enhance outcome.
Oh, yes. And a lot of people are not fit enough for the pancreatic cancer chemotherapy. They are usually very toxic, even for young ones and the pancreas itself. So, true, this is going to have more people chance to get at least the treatment. And for some, it might improve and later on give a chance to another treatment and options. And another thing that you mentioned is that unlike chemotherapy, this is an oral pill, so this will also improve the quality of life. Do you think it actually affects how people are getting into the treatment and preference towards some of the treatments?
Yes, I think we hear this very vocally in the clinic. There's a
Mm.
huge interest. People are reading and hearing about the story, and I think want to be part of that, and hopeful as we are for them with what this may bring to their health. And yes, I mean, the idea of flexibility in terms of their life, less restricted and tied up with chemotherapy, and just also feeling better. I didn't. We do our best to manage chemotherapy and to try to make it as comfortable and as sustainable as possible, especially when it's doing a good job controlling the disease. I think we all recognize it comes at a price on the body, and sometimes that is very manageable, but sometimes it's challenging, even in quite fit, healthy people. And so the fact that the ability to deliver a treatment and to sustain that treatment on a longitudinal basis is feasible with this class of drugs. Just it opens up a whole new way of thinking about this disease and people's perspective on this disease and also the fact that we now have this major positive study is it gets more people focused on pancreas cancer. It's more drug development. It gets more funding. It gets more talented scientists and young investigators focused on this disease, all with this, incredibly important goal of changing the standard of care and improving outcome for people with this cancer.
So you shared a lot about the biology of cancer and that you studied it a lot. Not in every center can be, I think, studied in that level that you are studying. What would be your ideal clinic? Like every pancreatic cancer patient should have the genomic profiling and sequencing all the time. What do you think about this?
Yes, I do think to kind of level set here, there are two, very basic and important considerations to help refine and select treatment choices is, building off our current guidelines is germline testing for every single individual. And just a reminder there, the guidelines are agnostic of any demographic, age, personal or family history. So everybody with the diagnosis. And I always tell our fellows, I picked up a Lynch family in an 88-year-old with pancreas cancer. And that was incredibly important to that patient and that whole family. And, so we just have to be age independent in our thinking. And that somatic testing is now equally important. And to do this as early as possible. And we typically will consider both tumor-based testing and ctDNA. And ctDNA has a virtue of the proximate timeline to get a result for clinical decision making in the front line. Tumor-based testing is the reference and gold standard, and that our ability to detect mutations is very contingent on the site of metastasis, the stage of the disease. So lower burdens of disease, less likely that we'll pick up findings on ctDNA, and more likely that we need the support of tissue. So we typically will use several modalities, but for day-to-day clinical care, somatic profiling, ctDNA, and germline testing.
Thanks for sharing. I think this also will guide the treatment choice for a lot of people.
Yes.
Some of people will not know if not tested, and it should be reminded that it's very important. And being age independent is very critical thinking to change. I think it is shifting how people look at the age. Because people tend to live in longer, and we are seeing very strange things happening, very young, very old. So it's very important that you highlighted this. And if we talk again in 5 years, what is the headline that you hope we're writing about in pancreatic cancer?
I'm hoping we'll have triple survival, and we have to be ambitious, right? We have to be focused, and that we're going to see the impact of these therapies. It'll probably take 2 years to see this in the annual data outcomes from the American Cancer Society to see this shift. But yeah, so I'm hoping we're currently around 12, 13% overall 5-year survival if you take all comers, that we can get it closer to 40%. That's ambitious. That's a lot. That's a high goal, but I'm for it.
Yes, but I think if there are no high goals, no one can reach it. And I think people who were ambitious make these things happen.
Is
If
it?
they were okay with what is the standard, we will never have the double of survival. So people like you, ambitious and scientific and driven with the rational and idea of helping, are the ones who create these triple survivals. Hopefully even more every 2 years moving forward, the more quickly as possible. Thanks a lot for sharing your perspective on this important study as someone who is not only the lead in the trial, but also the one who is caring for these patients and moving the research in pancreatic cancer forward. We did so these 13 months, but it's not only this. This is also how we think about the pancreatic cancer biology itself. And it was absolute pleasure, Dr. O'Reilly, having you today with us. And thanks for sharing all of your insights and your ambitious thoughts on the future.
Oh, thank you so much. Pleasure to be here. Thank you.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.